There you are. How are you?
Denise, I thank you so much for having me. We are huge fans of your work and of WIN, and really excited to talk with you today, you and your viewers today.
Thank you. Thank you. And so, yeah, I mean, this is interesting to me. Of course, most of us who are, have been mothers, and understand that, it's by the grace of God that we were able to have a positive experience. But why is it that Blue Cross Blue Shield has decided to address this issue of reducing health disparities or racial disparities in the area of maternal health by 50% in 5 years? That's quite a challenge you've taken on.
It is a bold goal, but I do think that for serious issues such as this, it requires serious solutions. Um, the United States is one of the richest nations on earth, and moms are dying at the highest rate in the developed world. And that rate is rising for all moms. But for as dire as the situation is for all women and birthing people, the crisis is most severe for Black moms who are dying at 3 to 4 times the rate of their white counterparts. Native Americans, for example, are more than twice as likely to die from pregnancy-related complications. And one study found that Hispanic birthing people experience severe maternal morbidity at almost 2 times the rate of non-Hispanic white birthing people. So Carefirst Blue Cross Blue Shield, in partnership with our plans across the United States, recognizes that this is a serious, serious issue. One other additional example is that in our study, severe maternal mortality rates are more than 63% higher for Black women than for white women. Black women aged 24 or younger still have higher rates of severe maternal mortality than white women over the age of 35. So I think ultimately these disparities are unconscionable and unacceptable. And the association, and certainly with Carefirst in huge partnership and leadership here in the region, is ready for action.
So, but my question is, I mean, what can Blue Cross Blue Shield do about it? I mean,
Yeah.
How do you all plan to address this problem?
Yeah, absolutely. I mean, I think the first is, I'm trained as a public health sociologist, as you said, not an MD, but a PhD. And the first component is really understanding the significance and magnitude of the issue. We launched our report partnering with the Health of America earlier in April. And now we're partnering with organizations right here in the region. So a few steps that we're taking to reach the goal, I think, around maternal and child health are first to acknowledge what we've already done, the progress that we've made. So since 2007, we've invested more than $20 million in maternal and child health programs around the Mid-Atlantic states, in Maryland, Washington, D.C., and Northern Virginia. One example includes a partnership with Mama Toto's Village, which provides comprehensive prenatal and perinatal care for African American and Latino women in wards 5, 7, and 8 in DC. And so that kind of programming, your question, what are we doing? Some of that includes home visiting services to clients from pregnancy up to 12 weeks postpartum, providing psychosocial support, life skills, system navigation, and doula services. Mama Toto's Village also ensures that they are engaging women early to ensure that prenatal care, for example, remains consistent during their first trimester, and things like breastfeeding initiation and adoption. And so, another example here in the region, in 2009, we started partnering with the Baltimore City Health Department. At that time, they had one of the worst rates of infant mortality in the country, really twice as high as the rest of the nation. And Black babies were 5 times more likely to die than white babies. So we've supported this program for more than a decade. It's called Be More for Healthy Babies. And I'm proud to report that because of this initiative, Baltimore's infant mortality rate dropped by 30% in the 10 years since the start of the initiative. So our goal is to take examples like Mama Toto's Village, like the huge partnership for Be More for Healthy Babies, and scale that program both here in the region and then in partnership with the association across the nation.
Is there any one thing that you can point to that you think really, really, really makes a difference? I know prenatal visits, I think, are important. Sometimes, even, we've known so many mothers who've lost babies, during pregnancy, even though they are making those prenatal visits. But is there any one thing that you can point to that you think really, and this is woman to woman now, not doctor to client, but woman to woman, that women should do that could make a difference in these drastic numbers?
I mentioned, Denise, that I'm a sociologist, and so I really think we need to flip the question on its head. That it isn't so much what we as Black women can do, but how can the systems and structures that are serving us improve what they are doing, right? So a lot of this is a multifaceted problem that requires multifaceted solutions. But I do think to the extent that we can begin talking about not individual behaviors, but institutional systems, that things like unfair policies, things like discriminatory practices, things like implicit bias that really systematically reproduce those racially inequitable outcomes. I think that's really what the findings of the study are promising, because they mean we're not putting all the burden on patients. That really we want to share that burden equally from nonprofit organizations who can provide education and services, from provider organizations that can look at cultural competency and re-examine how their practices in that patient and provider relationship can be enhanced. That means resourcing federally qualified health centers and hospitals and more. So the study and the report is really a basis for saying at every level, the individual level or micro level, the meso level, the macro level, it takes all of that to solve this.
I can kind of see what you're saying, particularly in a community where we are, where a hospital, closed its maternal health, division, and women now had to travel, across the city, and they're not doctors in the community that they can see. So I get your point there when you talk about systems that are in place that contribute to the problem that need to be addressed.
Yeah, and you know what I would also say? The other thing is, and I was talking to your producer, Shevry, yesterday about this. The other piece I think that this report gives a sort of additional spotlight on is that maternal and child health isn't just a clinical problem, right? That we can't just look at this as a solution to say, better prenatal care solely. So much of what contributes to your health happens outside of your doctor's office. As you just mentioned, when access points are closed and transportation barriers exist, that's huge. And so a doctor isn't going to write a prescription for an Uber, let's say. So I think another part of what we can do is look at maternal and child health and so many other chronic conditions, and the root causes being social determinants or economic determinants of health. And so really a universal basic income pilot, or supporting individuals in accessing food, ensuring that basic needs are met in the household, that there is light and gas and those other elements that are present. So I think the social determinants of health is also another promising direction that says a woman can take all of her prenatal visits and prenatal vitamins and go to the doctor each time. But if we're sending that healthy mom back to a sick community, we haven't gone far enough. And I think insurers are excited about playing a role in addressing the social determinants.
So before we end, I do want to ask, because this sounds like a bigger problem than what one insurance company can manage, and it takes partners and other institutions to get involved. So how is that working?
Yeah, I think that's an absolute excellent point. Here, certainly Carefirst, along with our community health plan of DC, partners are looking at, grassroots organizations and anchor institutions, and that includes the micro, like perinatal case management. It also includes partners like March of Dimes, Healthy Beginnings, Lucina, Pacify, and other kinds of organizations and technologies that better equip moms and their ecosystem with the tools that they need. And so I think you're right. We're partnering, for example, in Baltimore City with local historically Black colleges to help us think through how do we message and effectively provide information to moms. But again, it also is a systemic approach. So we're doing the same for our provider networks. We're looking at new incentive ways that we incentivize the addressing of social determinants of health through models like value-based care. And then finally, in DC, it also includes, again, that tailored case management. Last year, we announced a partnership with an organization called City Block DC, who also is going to be providing special and tailored services to our Medicaid population. So I think this is a wraparound, this is a partnership approach. Carefirst know that we can't do it alone, so we need to partner with not just institutions, but individuals that have great ideas as well.
Well, wonderful. I'm glad that you joined us today to give us, that snapshot of what you all are engaged with and how it will impact our community all across the city and the region. So thank you so much. Know that the Washington Informer wants to be a partner as well. So anytime you have more information to share, feel free to come back and join us. And, we want to track that. We want to make sure that you reach that goal, because that goal is a positive one for all of us. So Dr. Destiny-Simone Ramjohn, thank you very much for being with us today.
Thank you so much, Denise. We look forward to partnering with you.
Where did you come to get off?